So we'll start with our plenary session. I'm Usman Ahmed, a clinical hematologist by profession. I was being given the responsibility to chair the symposium. Welcome to our plenary session. It's the largest oncology meeting in Pakistan. It's a platform to provide, it provides a platform to leading researchers, scientists, practitioners, and trainees, and being attended by diverse delegates. This year, we have more than 100 speakers, out of which 69 came from, were international speakers and came from 14 different countries, excluding Pakistan. So this annual symposium is being made a reality by a work being done by diverse team members from various departments. And the work actually starts when the previous symposium just finishes off for almost a year. So they worked tirelessly for almost a year behind the curtains. And I'm going to unveil this curtain. So we've got from HR department, Miss Anika and her team members, which is the heart or a secretariat of this whole symposium and coordinate that. And then we've got facilities department being led by Mr. Farooq, and we've got Saqib Saab there. And from travel and logistics, we've got Mr. Nasser and Farooq Saab. And then we've got our IT team being led by Ms. Sara. And of course, marketing department is there as well, being led by Mr. Obad. And we've got porters, security, and transport to make this happen and to get the smooth functioning of the symposium. Our next talk is all about how this symposium has transformed and evolved over years. It's about how Shaukat Khanum Hospital has transformed from a dream of a person who has had an iron will and a strong determination to make this reality. For us to go through this whole journey, we've got none other than one of our persons who have been working tirelessly and dedicatedly in this organization for the last 30 years and has been an integral part of this organization. So I give you Dr. Muhammad Asim Yusuf, our Chief Medical Officer and an esteemed gastroenterologist. Dr. Asim, please.
Assalamu alaikum. Good afternoon. It's a pleasure to have you all here. Thank you. I'm not sure what an esteemed gastroenterologist is, but I'm happy to be called one nonetheless. Thank you. So in the next 20 minutes or so, we're going to give you a sort of summary of it's 30 years of Shaukat Khanum functioning later this year. December 1994 is when Shaukat Khanum Hospital opened in Lahore. So we're going to give you a little bit of an overview of the past 30 years, the issues that continue to confront us in oncology in Pakistan, a little bit more about the history of the hospital, and then the symposium itself. So we're going to talk about the challenges of cancer care in Pakistan. We have a huge burden of disease. Far too many of our patients present at an advanced stage of their disease, leading to delayed diagnosis and fewer treatment options. We have a paucity of treatment facilities and of trained personnel. There is also a shortage of accurate data on cancer and the stages at which patients present and so forth. Costs of treatment, I guess, are a problem the world over, but are particularly magnified in our situation. We have a number of regulatory issues, and we have a slowly developing, but still a nascent research culture in Pakistan. So it's estimated that there are about 180,000 new cancer patients diagnosed each year in Pakistan. Because of the advanced stage at which they present, about half of those will die within the year of diagnosis. 180,000 patients is low relative to our population. As an example, the UK, with a population of about a third of ours, has over 300,000 new cancers a year. The US, with a population only slightly larger than ours, I think, has 1.8 million new cancer diagnoses each year. But that number is very high relative to the facilities available to diagnose and treat these patients. Delayed diagnosis, again, is multifactorial. There's a lack of awareness of cancer, certainly amongst patients, but also, unfortunately, all too often amongst physicians. There are stigmas around cancer, particularly for female patients. Breast cancer is the commonest cancer we see in Pakistan, and all too often female patients will be scared and embarrassed about discussing the possibility of cancer with family members and so on. There's a fear of rejection. Children, particularly female children, will often be taken to doctors later than male children. And, you know, we're a largely agricultural economy even today. And it's well known that in crop cutting season, for example, the care of patients who need a male person to bring them to hospital will often be delayed until the crops have been cut, which can be a couple of months. There is a shortage of diagnostic facilities and a poverty of knowledge as to the optimal means of diagnosis and of treatment. All of these result in too many patients presenting at an advanced stage. We have excellent physicians. Many of you are Pakistanis who have excelled here in Pakistan and overseas. Nurses and other clinical staff likewise. We have no shortage of well-trained, dedicated, educated, highly motivated people. But there are often not enough places for them to work in. There are few dedicated cancer diagnosis and treatment centers. And all of this means that often care is disjointed. There may be excellent surgical facilities in a number of hospitals. Some hospitals may have radiation treatment facilities. Others may provide chemotherapy, but it's unusual for a patient to get all their care in one seamless manner in one institution. And of course, this makes a multidisciplinary approach to cancer all the harder. We talked about personnel to some extent. We have good people, but there aren't enough of them. There's an extreme shortage not only of doctors, but of nurses. Some estimates suggest that there are up to 1.2 million nurses short in Pakistan, and it'll take us decades to train that number of nurses. The same applies to ancillary and allied health professionals. And of course, we're always at risk of having our best and brightest poached. For us at Shaukat Khanum, that's a problem, and I'm sure in all your hospitals it's a problem that people who work in a good institution are liable to be offered jobs elsewhere in the country, and that's part of our mission statement to expand the facilities for cancer. But all too often these critical staff are poached for overseas positions in the Middle East and in the UK and the US, despite various agreements and signatures from various very well established people condemning this practice and assuring the third world that they will not poach there. They will not contribute to this brain drain. It continues to occur. The solution obviously is to have more domestic training programs, to have more facilities, better infrastructure so that these people can be absorbed locally. We can afford to pay them what they deserve, and we can provide them with the facilities that they need in order to practice. We have established some innovative solutions in our own hospital, and I'm sure others have done the same, but many more of these are needed. There is or has been traditionally very little data on cancer. There are a number of institutional registries that have been active for many decades, but there is no national cancer registry per se. The first attempt at establishing a population-based cancer registry was the Karachi Cancer Registry, which started in the 80s. But unfortunately, in the late 90s or early 2000s, this became dormant for a number of years. And we at Shaukat Khanum have established, with the help of colleagues, initially all across Lahore and now all across the province of the Punjab, with a population of about 120 million, the Punjab Cancer Registry, which is a population-based registry and currently the largest population-based registry in the country. And more recently, following the opening of our second hospital in Peshawar, we've also launched the Northwest Cancer Registry, which covers all of the Khyber Pakhtunkhwa, Gilgit-Baltistan, the former federally administered tribal areas, and unoccupied Kashmir and Kashmir. Costs of treatment, as I said, are a global challenge, but these are greatly amplified in low and middle income countries. Every day there are newer and ever more expensive drugs, machines like linear accelerators, and of course robots. Robots seem to be taking over, if not the world, then certainly medicine and surgery. And obviously there are pressures from the trained physicians that we employ that they want to be given the tools that they need to be able to practice their craft. Patients are increasingly well informed and ask for, the latest treatments. We're a charitable organization funded by charity, and our funders and donors also insist that we be at the cutting edge of diagnosis and treatment. And of course, the media plays into this constantly. We are a highly regulated and legislated society. We have provincial healthcare commissions to whom we report, and that is only right and proper, obviously. But there are naturally, if you operate in multiple areas of the country, such as we do, we have to comply with the Punjab Healthcare Commission, the Khyber Pakhtunkhwa Healthcare Commission, and the Sindh Healthcare Commission. In addition, there are professional regulators for physicians, nurses, pharmacists, and others. And unfortunately, there are often relatively outdated laws which regulate many aspects of the practice of medicine, in particular to do with medication or drugs, which make it more and more complex to be able to practice. And finally, we're a highly litigious society, and patients are very, very keen to discuss their care with lawyers and see whether anything went wrong. There are numerous opportunities for research in our country. We have a huge number of patients. Gradually, there is a developing culture of research, both in basic sciences as well as clinical sciences. A number of institutions in Pakistan now collaborate on research, and we also collaborate with institutions overseas. And obviously, your presence here today is reflective of that. And we now also have clinical trial units in a number of hospitals across the country. So coming to Shaukat Khanum and what we've been doing for the last 30 years. So for those of you who don't know, and I hope that visitors who haven't seen the hospitals will spare the time to come and see our hospital in Lahore before they return, if possible. If not this time, then certainly on their next visit. So the image in the center is our hospital in Lahore, which opened in December 1994. On the left, as you look at it, is our second hospital in Peshawar. And on the right is the architect's rendering for our third hospital, which is currently under construction in Karachi. So the inspiration for this came from Imran Khan, who was the captain of the Pakistan cricket team, a household name across the world, later became our prime minister. His mother was called Shaukat Khanum, and like so many people in Pakistan, she was diagnosed with colorectal cancer in the early 1980s, and like so many others, presented at an advanced stage of illness, and it was not possible for her to achieve a cure. But during his mother's illness, Imran accompanied his mother on her cancer journey, both within Pakistan and overseas. And he was struck by the shortage of diagnostic and treatment facilities, first of all, in Pakistan, but more importantly, by the people that you see at the bottom of that image, the masses of Pakistan who did not have the same opportunities that Imran had in terms of money to pay for tests and treatment and the money to take his mother overseas for treatment, which he did. These were patients who had no money for simple analgesics, for simple tests like full blood counts and urea and electrolytes and so on, let alone expensive cancer diagnostics and treatment. And Imran always says that it was the suffering that he saw amongst these people that really inspired him to make a cancer hospital that would be free for everyone that came and was accepted for treatment, regardless of whether they could pay for their care or not. Just in case anyone doesn't know, the second circle that just lit up, that's Imran as a child, and the lighter circle is his mother. So the plan for the hospital in Lahore was developed in 1988, and in 1989, a worldwide fundraising campaign was commenced, primarily initially in Pakistan, but then also wherever there was a Pakistani community overseas. And at that time, it was largely in the Middle East, the UK, and the US. The diaspora there contributed significantly and wholeheartedly. Construction began in 1991, and on December the 29th, 1994, the hospital in Lahore opened. It was opened by one of our first patients. And then in 2015, our second hospital in Peshawar opened once more by a pediatric patient, also opened on the 29th of December 2015. So Lahore will complete 30 years of function at the end of this year, inshallah, and Peshawar will complete 9 years. And just because a number of people still ask today, Peshawar has all the facilities that we have in Lahore. It is a tertiary care, diagnostic and treatment cancer facility, just as the hospital in Lahore is. And inshallah, Karachi will be the same in years to come. So this is our mission statement. It's rather wordy, but we've highlighted the main features. So first of all, we aim to act as a model institution to show that it is possible to achieve excellence in Pakistan And again, you are thought leaders in your fields. This is clear and evident to you, and I'm sure you do it in your own institutions. But all too often we encounter this sort of nihilism in Pakistan that this is not possible here, and you can't do this here, and you can't do that here. Oh, this is all very well in the West, but this can't be done here. And we like to show that, we like to think that over the last 30 years, we have shown that it is possible to achieve excellence in Pakistan too. We're a cancer hospital, obviously, so everything we do centers around, focuses on cancer. The most important part of our mission is in the 5th and 6th lines, which is that once a patient is accepted for treatment, all treatment that they get, all diagnostics and all treatment that they get are provided irrespective of whether they can pay for their care or not. We have a role in education of healthcare professionals and the public, and that one of the major manifestations of that is our Cancer Symposium, which is now held annually. And of course, we perform research into the causes and treatment of cancer. So our core values are quality and equality in terms of access, how patients are accepted for treatment, how do they get appointments. There is no difference between those who can pay for their care, which constitutes about 25% of our patients, and those for whom the hospital provides supported treatment, which is the other 75%. Similarly, the clinical facilities, so the doctors they see, the tests they have, the treatments they have, are all entirely identical. And doctors and nurses are blinded to the patient's financial status. So when we're treating patients, we don't know who's paying and who isn't. This also extends to the hotel services. The rooms that patients are admitted to are all for 2 patients. We don't have wards. We don't have VIP rooms or private rooms. And it's common for 1 bed in the room to be occupied by a patient who's paying for their own care, and to have on the bed next to them someone for whom the hospital is paying. Finally, we like to think that the care we provide is truly holistic. 12% of our patients are children, many of whom have never been to school. Others will have been to school but will lose a significant amount of school time because of the to and fro that occurs during cancer treatment. It may last up to 2 to 3 years of active treatment for children. And it's then very hard for a 7-year-old to go back to school with kids who are 4 years old, maybe half his size or her size. So what we started in 2015 was a hospital schooling program, which is entirely voluntary. What we do is we get children to get their teachers to write down the curriculum that they would need to study for that year. And then we have volunteer teachers as well as our school teachers and staff who come in and teach these children in their own free time. And as a result, we've had 770 children who've gone through this program, many of whom had never been to school before, and many others who are able to go back to their appropriate, age-appropriate class when they do go back to school. I work for Shaukat Khanum. I've worked for Shaukat Khanum forever, so I'm obviously going to say that everything is fantastic and we're a really wonderful institution and everything is hunky-dory. But luckily for all of us and for you and for our donors and for the public, we have a number of external certifications which validate and verify what we're saying. So we are Joint Commission International certified. Both of our hospitals in Lahore and Peshawar are individually accredited by the Joint Commission International, which is a US organization which accredits US hospitals. They apply the same standards to overseas hospitals, and our hospitals in Lahore and Peshawar were the 3rd and 4th in Pakistan to achieve that accreditation. In 2022, the Joint Commission started a new form of accreditation, which is ideal for organizations such as ours, which have multiple campuses, called Enterprise Accreditation, in which they did a 3-week survey, US-based surveyors, 3-week survey of all our facilities, Lahore, Peshawar, Karachi, our diagnostic centers. And in 2022, we became the 2nd organization in the world to have enterprise accreditation from the Joint Commission. Our oncology program is accredited by the American Society of Clinical Oncology in Lahore and in Peshawar. Very, very recently, less than 2 weeks ago, we received formal acknowledgement of the accreditation of our pathology laboratories in Lahore by the College of American Pathologists. And we have a number of other food, engineering, and other services that have been accredited by ISO. We are a paperless hospital. We have an electronic medical record system, which we've developed in-house, which is used across all our facilities all across the country, and which we've donated to a number of institutions in the public sector. That is CMMI, accredited, which is one of the highest forms of accreditation in the IT industry. And this is not an accreditation, but we didn't want to let this pass. We are one of only a few organizations outside the United States whose pharmacy residency program is accredited by the American Society of Health System Pharmacists, and both Lahore and Peshawar have that accreditation. In 2023, which is the last year for which we have full figures, we accepted 13,500 new patients across the two hospitals. In addition to that, we have about 35,000 patients in active follow-up between the two institutions. So about 50,000 patients with cancer are being seen in the hospital at any given time. This generated over 300,000 outpatient visits, close to 80,000 radiation treatment sessions, again, just over 80,000 chemotherapy sessions, and 18,000 surgical procedures. I've talked about this before. Consistently since 1994, over 75% of all our cancer patients have been treated completely free of charge, and we've spent over $710 million in providing philanthropic treatment to needy cancer patients. Our commitment to research ensures that we perform research to the highest scientific and ethical standards. We have an Abdul Hafiz research wing endowed by a generous donor, which consists of a clinical research office, the cancer registry, and our basic science research labs. And we also have one of the few journals in Pakistan, which is PubMed indexed, which is run out of the Shaukat Khanum Cancer Hospital, called the Journal of Cancer and Allied Specialties. I would encourage you to consider this journal for your publications. As I said, it's PubMed indexed. And very importantly, nowadays, there's no publication charge. Sorry, and as you'll see at the bottom right, the number of publications from the institutions has gone up each year for the last several years, close to 1,500 peer-reviewed publications from Shaukat Khanum now. This is a very recent photograph of the third hospital in Karachi, which is under construction. This is twice the size and will have twice the facilities of the Lahore hospital. It's over 1 million square feet, and we hope that this will be up and running within the next couple of years, inshallah. I talked about the cancer registries, so I won't dwell on that. But I will point out that I said that there was no national cancer registry, but Globocan and the WHO all, I don't know if you can see that, they all reference the Punjab Cancer Registry as their source of data for the countrywide data that they present for Pakistan. So the Punjab Cancer Registry is essentially the de facto national cancer registry at this time, and we hope to continue to expand its coverage to include the whole of the province of the Punjab, and as with the Northwest Cancer Registry develops, that will add to this. So here we are in Lahore at the symposium. Usman has mentioned some of these things, but there's some things particularly close to my heart that I have to say. So Lahore is an ancient city steeped in culture and history with a recorded history of about 1,600 years. It's over 2,000 years old, so it's one of the oldest cities in the world. It's been a center of learning for centuries, and it has a very, very long tradition of hospitality. And as I'm sure that many of you have discovered, we have food to die for. So another reason to come and keep coming to the symposium. Usman mentioned this. We are accredited by the AACME for 33.75 credit hours. And this is now Pakistan's largest cancer meeting. And very importantly, it's run entirely by Shaukat Khanum from its own funds. There is no commercial sponsorship, and that's why you'll have seen there's no pharmaceutical industry or other representation. There's no commercial exhibit, none of that. It's entirely without commercial sponsorship, so that all the research presented here is entirely based on scientific merit with no other considerations. This is the organizing committee. I'm not going to go over everyone, but Usman is the chair. Faisal is the co-chair. I think he must be here somewhere too. I can't see him. And he will be the chair for the next symposium next year, inshallah. Some stars of the symposium every year, and many of you will know. Anika, where's Anika? There we are, right at the back. Anika is really the heart and soul of the symposium. And yes, absolutely. Deserves a big round of applause. But, you know, there's so many others, Nasir Saab and Farooq and others that Usman has already mentioned. We also have a strong scientific committee, too many names to mention, but everyone played their part, and we're very grateful to them. Is Mr. Ahmed in the audience? The head and neck surgeon? Oh, well, okay. Anyway, so again, Usman showed that there were 47 national speakers, 69 international speakers from 14 countries. And as you'll see, some of them ran all the way from the UK. So this is Mr. Ahmed, who's one of the head and neck surgeons who's speaking today, running the half marathon in London. But you'll see that he's got the Shaukat Khanum logo on his, what's it called, singlet? I forget. Anyway, the shirt he's wearing. So we encourage you all to do that sort of thing when you all go home and run to support Shaukat Khanum. We've had some pre-symposium workshops on pathology, radiation physics, and surgical oncology. And each year we have an ever-increasing number of abstracts and free papers presented. This year we had 384 high-quality abstracts to choose from. Another highlight of the symposium is the Ehsan Rashid Memorial Medal for the best research presented, and that'll be tomorrow at 4 o'clock. And we also have the Bashir Alavi Award for the best cancer publication from Pakistan in 2024. Each of these will be judged by an independent panel of judges. Some personal highlights for me have been and will be tomorrow as well. Talks on NGS, robotic surgery, of course, AI, of course. No medical conference is complete today without multiple sessions on AI. And a talk on antibiotic stewardship in cancer patients. And of course, our plenary talk and our speaker, who's going to be introduced shortly, will be about CAR T cells. There is also an addition to the program, which many of you may not know about. It has been added a few hours ago on the screens outside, but in case you didn't catch it, this year we're honored to have two surgeons from the University of Oxford, Professor Nick Maynard and Dr. Michael Silver. I tried very hard at midnight last night to find a picture of you both on the internet, but I could only find a picture of one. But nonetheless, these are two surgeons from Oxford who've been speaking here and who have been visiting, teaching, and operating in Gaza for many years, including this past year. So after the plenary talk, and this is a break from tradition, normally the plenary talk is the main talk of this event. It is still the main scientific talk, obviously. But we've got a second talk after that, a shorter talk by Professor Nick Maynard about the challenges of providing healthcare in Gaza, which I think will be of great interest to everyone here. Finally, we have an app, which I think you've probably all got on your phones, which not only shows you the program, but which will also allow you to claim CME credit, which you can continue to do after the meeting is over. So I'm sorry if that dragged on a bit, but thank you again for your interest and your attendance and your support of the Shaukat Khanum Cancer Symposium. We look forward to seeing you again next year. The dates are continuously up on the screen, but it's exactly 52 weeks from now, Friday the 24th, Saturday the 25th, and Sunday the 26th of October, 2025, here in Lahore. Inshallah, we'll see you then. Thank you.
Thank you, Dr. Asim. So let's get to the crux of the matter. Our next talk is our plenary talk, which is about CAR T cells. CAR T cell is a cutting-edge technology where our immune cells can be transformed into cells which can fight cancer. Our plenary speaker is Professor Muzaffar Qazalbash, who is a professor of stem cell transplantation at MD Anderson, Houston, USA. It is a well-renowned cancer center all around the world. Professor Muzaffar has got more than 300 publications in peer-reviewed journals throughout his career. He has co-authored 6 books, and his areas of interest and expertise include stem cell transplantation in multiple myeloma, cancer vaccines, and immunotherapy. So I'll invite Professor Muzaffar Qazalbash to please take to the stage.
Okay. 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 Very good. So this is the back. Okay. Perfect. Gee, thank you so much, Usman, for the kind invitation. Thank you to the organizers for the opportunity to come and present my work. Of course, I am not new to coming to Shaukat Khanum as a speaker, and it's always my great honor to come to this great institution. And just a little anecdote that my career in hematology oncology started approximately the same time as Dr. Yusuf pointed out that Mr. Imran Khan had the idea of developing a cancer center. And I can tell that when I would tell my colleagues and my teachers in late 1980s that I wanted to be a hematologist oncologist, I would be ridiculed that this is an insane idea because it just cannot work in Pakistan. And this cancer research hospital, of course, is an answer to basically that ridicule. So thank you very much. So I'm going to touch upon evolution of cell therapy for blood cancer. So you heard about CAR T cells, and that would be just one component of my talk. I would basically give you a little evolution of how we got to CAR T cells, and then show a few slides on what is so special about these CAR T cells, basically. So my next slide. So before we go to cell therapy, I want to talk a little bit about cells. So what is a cell, basically? So first described by an English scientist, basically a polymath, Robert Hooke, in the 17th century when he observed or described what's called the cell today. That was in 1665. He built a compound microscope, examined a thin slice of cork, and noticed that it was made up of very small boxes. So these boxes looked like cells where monks used to live. So that was the origin of the term cell. And then the first time someone actually described, okay, thank you. And sometimes, later on, when someone actually described a living cell, was basically the inventor of the microscope, Antony van Leeuwenhoek, a Dutch, now you can call him a scientist, in 1674. And he basically looked at the rainwater and saw these little particles, called them animalcules. So these were basically bacteria and protists. So this is how we first came to find out what a cell is. So with that, about a couple of hundred years later, so they saw the cells, but they did not know what the cells were actually doing. And that was up not until 19th century when the classical cell theory was proposed by Theodor Schwann, who was a physiologist, and by Matthias Schleiden, a botanist, both in Germany in 1839. And that's basically the origin of the cell theory, that all organisms are made of cells. Cells are the basic units of life. And then later on, another famous German physician and scientist, Rudolf Virchow, in 1855, added this, that all cells come from cells. So this is basically the genesis of cells. And now from that, we have come to this complex structure which performs almost all the functions of life. This song of the cell is from the title of a book by a physician based in the United States who has written a bestseller book on the history of cancer called The Emperor of All Maladies. His name is Siddhartha Mukherjee, and one of his books is basically about cells and what we know about it. And it's a very well-written book, and the title is The Song of the Cell, that how all the things, and you can see these multitude of functions that are performed in the cells and gain much deeper understanding about its interconnectivity, and it touches upon all those things. So again, it's a journey. So from that, this field of cellular therapy basically started with stem cell transplants, also called bone marrow transplants. So what are these stem cells? So we all have stem cells in our body. The cells that we work with as hematologists, oncologists, are blood stem cells or hematopoietic stem cells. But regardless of which organ has the stem cells, they have these two distinct properties. They can differentiate into mature cells and they can self-renew. So these are the two basic properties of stem cells, and which allows these stem cells to regenerate a bone marrow that was completely eradicated by chemo or radiation therapy. So these hematopoietic stem cells primarily reside in the bone marrow. And now we have the means to identify them. And they can be identified through some cell surface markers that can be detected by simple tests like flow cytometry, simple today with all the advancements in technology. So these cell surface markers, and to briefly describe them, some of them are CD34 and CD117 positive, and then they have the absence of lineage markers. So they are not lymphocytes or monocytes. So that lineage is missing. So this is the start of the modern stem cell therapy, the basic understanding of stem cells. So the beginning of stem cell transplantation was actually not very auspicious. So if you look at the history, it all started with the atomic bomb explosions at Hiroshima and Nagasaki in 1945, where radiation caused acute burn injuries, or the deaths were mostly caused by burn injuries, radiation sickness, and then eventually bone marrow failure. And that made many scientists, including hematologists, think that how could they reverse if such a catastrophe was to happen again in the future. And there were scientists who were working on stem cells. In 1949, one of the scientists, Leon Jacobson, showed that there are adequate number of blood-forming cells that survive in the spleen of mice if they were shielded during radiation. So this experiment is often credited with the start of the field of bone marrow transplantation, that there are cells in the body that can basically survive radiation and can rebuild the entire hematopoietic system. And in 1961, these two Canadian bone marrow in mice can be reversed if you infuse normal bone marrow from healthy mice. So this is basically the genesis of the field of stem cell transplantation or bone marrow transplantation. So first transplant, first bone marrow transplant in humans was performed by Dr. Donald Thomas, and this was in Cooperstown, New York. It's a small town in upstate New York where he moved from Harvard University, which did not allow him to develop his transplant program. And there he started treating patients, but unfortunately, most of these patients had transient recovery of their blood cells, and then their bone marrow failed again. This paper was published in New England Journal of Medicine in 1957. Similar experiments were performed in France by Dr. Georges Marté, and he performed allogenic transplants in Paris, bone marrow transplants, on 6 physicists from Belgrade and what was Yugoslavia at that time, who were exposed to lethal radiation in one of the nuclear accidents. And unfortunately, again, most of these passed away, and the graft did not survive. So there was a paper in the early 60s which clearly showed that all human allografts failed, with just one rare exception. But we have to keep in mind that although they were performing these bone marrow transplants, but they did not understand the complexities that were needed to perform this procedure successfully. They did not know anything about hematopoietic stem cells and what they do. They did not know anything about the tissue matching or HLA matching. Did not have any idea about what's called graft versus host disease or graft versus leukemia or tumor effect, as well as very little knowledge of the immune system, including both the innate as well as adaptive immune system. So all these things, and I will take you through that briefly through my presentation, we got to understand in the coming years. So before we get to that, what is this bone marrow transplantation, especially allogeneic transplantation performed from a donor? So, of course, there are many colleagues who do this here in this institution, but for those who do not have exposure to allogeneic transplantation, basically high doses of chemo or radiation therapy is given to a patient with generally blood cancer or some other blood disease to eradicate the underlying disease or bone marrow. And it's also given to suppress the recipient or patient's immune system so it can accept somebody else's cells. And this is followed by intravenous infusion of these donor cells, so-called hematopoietic stem cells, to reestablish the blood and immune system. And the major benefits of this allogeneic transplant, especially in a blood cancer patient, comes not just from the chemotherapy, which is used to eradicate the underlying disease, but also comes from this immunologically mediated graft versus tumor effect. That was not understood or was not thought to be the mechanism when the first transplants were performed, that there could be an immunological graft versus tumor effect mediated just by the cells of immune system. So then comes a better understanding of this tissues histocompatibility, major histocompatibility system and HLA antigens. You will see and hear this a lot in the setting of stem cell transplantation. So this major histocompatibility complex is a region of highly polymorphic genes on the short arm of human chromosome number 6. And these protein products made from these genes are expressed on the surface of a variety of cells. And they basically display, that's another function of these HLA antigens. They basically display antigens to T lymphocytes. And they are the principal determinants of graft rejection and graft versus host disease. So in order to perform a successful bone marrow transplant, we have to understand this HLA system. And this in human beings is called the HLA or human leukocyte antigen system. So there are two classes of this MHC. HLA antigens, they play a role in immune system. They differentiate self from non-self, or in other words, that's how the grafts, whether it is kidney or liver or bone marrow, is rejected or accepted. So there are two types of HLA antigens, which basically present antigens to T lymphocytes, and the organs that are transplanted between HLA matched or HLA identical individuals are accepted in general. But in contrast, organs that are transplanted between mismatched individuals, and that's true for bone marrow also, are almost always rejected if not properly accompanied by immunosuppressive drugs. So again, these HLA antigens or MHC were not known when the original transplants were performed. Another thing that was not known, that when you give someone donor cells, they can basically attack other organs of the patient or recipient's body. And one of the manifestations is something called graft versus host disease, where the donor T lymphocytes cause morbidity and mortality in patients after an allogeneic transplant. And this is a multi-organ syndrome that can affect skin, gastrointestinal tract, or liver. And this could present as both acute or chronic graft versus host disease, or sometimes one merging into the other, or so-called overlap syndrome. Another thing that we got to understand after original transplants were performed were innate and adaptive immune system. And this has played a significant role in the development of CAR T cells and other cellular therapies that I will be alluding to. So the immune system, we all have an immune system, and especially in us or in primates or later organisms, there is an innate immunity and there is an adaptive immunity. So the innate immunity is something that is present in the smallest of organisms. It's a more primitive immunity. It detects huge differences in molecular composition between organisms. So a human can easily detect that there are bacteria or viruses invading our bodies. And this innate immune system depends on white blood cells like granulocytes, macrophages, natural killer cells, and the production of cytokines. Adaptive immunity is something that has come later in the evolution, and it is developed in more complex multicellular organisms. And this detects very subtle differences. Just a molecular difference can be detected by the adaptive immune system, and that's why one brother can reject another brother's graft because of subtle changes in the molecular system. And this is mediated by B and T lymphocytes. So with all these complexities, the first successful transplant, which is now part of the transplant folklore, was between these two sisters. This was in 1960. One of them developed aplastic anemia. Her doctor found out that Dr. Don Thomas, whose picture you saw, who got the Nobel Prize in Medicine in 1990 for performing the first successful transplant, he was invited to do a bone marrow transplant in Seattle. And this patient had an identical twin sister, and that twin sister was used as a donor. This is called a syngeneic donor. Her bone marrow cells were collected and infused to her identical twin sister, and within weeks, the child with aplastic anemia who was left to die fully recovered. But keep in mind that this was an identical twin transplant where there are no HLA barriers. An identical twin is just like our own genetic constitution, so it does not require any immune suppressive treatment, or there is no risk of graft rejection there. So from that early success, the field of stem cell transplant has grown tremendously. From its disappointing initial start, as you saw, that initially almost all the patients who received the transplant died. But now almost 90,000 transplants are performed worldwide across more than 80%, across more than 80 countries, and Pakistan is one of those. Approximately 50% of those are autologous transplants, meaning taking patients' own cells. And around 20,000 stem cell transplants are performed in the US, which is the largest number according to the International Bone Marrow Transplant Registry. I have a recent data which was published in a journal in Pakistan by Dr. Natasha Ali and General Parvez Ahmed that in Pakistan, the latest figures were from 2021 and 2022, and approximately 800 plus transplants were performed in Pakistan. As you can see, most of them are allogenic transplant, meaning from donor. But again, depending on the population, the resources where we have the greatest benefits, most of these allogenic transplants were not performed for blood cancers, but for conditions like aplastic anemia, thalassemia, and hemoglobinopathies in children who could get the maximum benefit from this potentially curative therapy. And there are, if I remember correctly from my reading, there are at least 10 to 12 transplant centers performing bone marrow transplant in Pakistan, including the one at Shaukat Khanum. So coming to, we talked about the benefit of allogenic transplant, not just coming from chemotherapy, but from something called graft versus leukemia effect. And we talked about the role of T cells. So in 1979, a landmark study of allogenic transplant, again from the group in Seattle, led by Dr. Thomas, showed that the risk of leukemia recurrence after bone marrow transplant was dependent on the presence of T lymphocytes in the donor graft. It was highest in identical twins, or because there was no disparity between the two immune systems, so there was no recognition of the leukemia cells being different. So there was no graft versus leukemia effect. It was less with allogenic donor. It was least with allogenic donors who developed graft versus host disease, meaning the donor lymphocytes were recognizing something different in the recipient and were going after the leukemia cells. And it was very high in allogenic transplant donors when T lymphocytes were removed from the graft, because people were trying to reduce the incidence of graft versus host disease, and they learned to remove T lymphocytes from the graft. But when they did that they noticed the recurrence of leukemia was going up. So this finding fueled the interest in this graft versus leukemia effect and the development of T cell therapies, which were independent of hematopoietic stem cell transplant. So with that came the next steps in the development of T cell therapies. And some of the earlier ones, donor lymphocyte infusion, tumor antigen specific T cells. And now we come to CAR T cells, engineered T cell receptor T cells, and natural killer cells. So I'll briefly touch upon these. So donor lymphocyte infusion was the earliest and the crude form of cell therapy. So patients who had bone marrow transplant and had recurrent disease, so in those patients, more cells were collected from the donor, and these lymphocytes were given to the patient without any more chemotherapy. It was just hoping that all they needed was a greater immune response, and it worked in a proportion of patients. But this only worked in patients who had relatively low volume disease of a slow growing cancer, like chronic myeloid leukemia with only molecular or cytogenetic relapse, not overt clinical relapse. But it was a proof of principle. Just by giving T lymphocytes from a donor can achieve a remission in a patient with recurrent cancer. So this was DLI, and this was one of the seminal papers that was published. Next thing, we tried to tweak these T lymphocytes. So now we thought that, well, if we can somehow make them more competent, if they make them recognize the antigens. So this approach called antigen-specific T cells. There are a number of people who played a role. Best known person is Dr. Steve Rosenberg at National Cancer Institute. This was the work that my colleagues and I did with something called idiotype antigen. But these antigen-specific T cells, so this approach focused on peptide antigens, which were expressed on the surface of tumor cells. And a number of different diseases were targeted. So the autologous T cells were collected from the tumor site, the so-called tumor infiltrating lymphocytes, or from peripheral blood. And then these T cells were stimulated and expanded in the lab against their target, and then infused back to the patients, hoping that these stimulated T cells, which were grown against specific tumor targets, would help in achieving a remission. So there was some early responses, but it was not dramatic. So the study that we did in patients with multiple myeloma, where we used idiotype antigen as the target, and we grew those T cells, and we did a randomized trial between a control group and patients who were given idiotype targeted T cells, although we saw better responses, but there was no prolongation in the duration of remission. So yes, T cells work, but we needed to do more than just stimulate them in the lab. So the next thing that you heard about is something called CAR T cells, chimeric antigen receptor T cells. So this work initially was done by Dr. Zelig Escher, the Weizmann Institute in Israel, and he replaced T cell receptors. So all T lymphocytes have a receptor, which is used to basically bind an antigen. But what he did was he replaced a T cell receptor with a B cell receptor to target the tumor antigen, because T cells do not bind to surface antigens as such. They need an HLA molecule. So although they replace the T cell receptor with B cell receptor, they maintain the killing function of the T cell. So that has both the B and T cell function, hence the name chimera, which is this picture from a Greek mythology where you can see basically the head of the head of a goat basically growing on this animal with a serpent tail. So that chimera term was used, that B cells and T cell machineries were combined. And this cell was called chimeric antigen receptor, or CAR T cells. And again, like any new treatment, initial results were disappointing. But then one of the hematologists and molecular biologists, Michelle Sadelain, or immunologist, discovered that to be effective, CAR T needed, in addition to their B cell receptor, a second co-stimulatory molecule. And that made these CAR T cells effective. And the first success with a CAR T cell was reported by Dr. Carl June and his colleagues in patients with chronic lymphocytic leukemia treated at University of Pennsylvania in 2010. And since then, there have been many successes with CAR T cells. So if you look at the United States, there are at least 6 different CAR T cells which are now approved by the federal the U.S. Federal Drug Agency, which has approved at least 6 different CAR T cells. 4 of them target the same antigen, CD19, which is expressed on the surface of B lymphocytes. So B cell lymphoma, B cell acute lymphoblastic leukemia, mantle cell lymphoma, they all have this antigen expression. And CAR T cells, and these are all T cells taken from the patients themselves, are given to these patients and have achieved unprecedented rates of remission, including cure in up to half the patients if they are treated with CAR T cells. There are 2 other CAR T cells that were developed for a disease called multiple myeloma, and they are targeting a different antigen, B cell maturation antigen, or BCMA, ide-cel and cilta-cel. Unlike lymphoma CAR T cells, these are not curative, but they do achieve a very high proportion of responses, and these responses are durable in a significant proportion of patients. So just to highlight, so these CAR T cells, one of them that was developed in multiple myeloma called ide-cel was recently tested in a clinical trial with standard of care treatment, a combination of 3 different drugs that are used to commonly treat multiple myeloma. And as you can see, there was a higher response rate with CAR T cells, as shown in the orange, compared to standard of care. And there was a longer progression-free survival, again, the orange curve, which is above, versus blue curve, which is below. And at the bottom, they talk about the toxicity. So these cells have some unique toxicity. So unlike chemotherapy toxicities of nausea, vomiting, and diarrhea, they produce more immune-mediated cytokine release syndrome that can cause flu-like symptoms that can sometimes be severely life-threatening. And they can also cause neurological toxicity, including confusion, handwriting disturbances, and they can even lead to coma and seizures. So they require very specialized settings and people with expertise on how to administer, and before that, all the manufacturing that goes into it. The second CAR T cells, cilta-cel, which is the more potent of the 2 CAR T cells that are approved for multiple myeloma, was also tested in a phase 3 trial in myeloma patients who have had 1 to 3 prior treatments and still had recurrent disease. And again, it showed that patients who received the CAR T cell had a higher complete response rate, a higher response rate, and again, a longer progression-free survival. So after about a year to 18 months of follow-up, the median progression-free survival in the control group was only about 11 months, while those who received CAR T cells did not even reach the median, or not even half the patient at that time had progressed. So again, showing that it is associated with significantly better responses. And because of that, both these CAR T cells are now approved for patients who have only had one prior line of treatment, which is an important for those who treat patients with multiple myeloma. In simple words, they can use these cells earlier rather than waiting to use them as the treatment of last resort. So, but the limitation of CAR T cells, that the antigen has to be expressed on the surface of tumor cells. And that is not the case for most tumors. And especially if you look at the cancer distribution, almost 85% of cancers are the so-called solid tumors. And there is no activity so far of any CAR T cell against solid tumors. So people are trying to come up with different type of genetic engineering to target solid tumors. So these are T cell receptor engineered T cells. So they are different from CAR T cells, that they also have an engineered receptor, but this is the actual T cell receptor and not a B cell receptor that is expressed on the surface of these T lymphocytes. And they represent a promising therapeutic alternative. And at least the theoretical idea is that they may improve tumor killing and T cell persistence by targeting antigens that are not just limited to cell surface, but they are presented by HLA-A2 on the surface of the cells of the solid tumors. And they also use the intrinsic physiologic T cell signaling and killing pathways, so they would also be more effective against solid tumors. But they have to be used in specific HLA subtypes, depending on the HLA subtype that is presenting the antigen in that patient population. So first early success of TCR engineered T cell was seen in a study in patients with synovial sarcoma, or soft tissue sarcoma, which is a tough disease to treat, especially after relapse. And again, these are very early or preliminary data, but it has shown some responses and some immunological parameters and biomarkers showing that how these TCR engineered T cells may be used to treat solid tumor patients. I have an ongoing clinical trial, but that is for a patient with multiple myeloma, but that will be a TCR engineered NK cell, which I will touch upon on the next slide. So far, all the treatments that you saw were with T lymphocytes, which are the main mediator of immune response. But we also have other type of immune cells, and one of them is called the natural killer cell, which is part of our innate immune system as opposed to the adaptive immune system. And it can identify and eliminate virus-infected cells and tumor cells. They are thought to play a pivotal role in anti-cancer immunity, and allogeneic NK cells, unlike T cells, do not cause graft versus host disease. So our group has used NK cells that are derived from umbilical cord blood to treat B-cell lymphoma. And there are ongoing studies that are evaluating the T cell receptor engineered in NK cells. And I'm leading the one in multiple myeloma, and one of my colleagues in the sarcoma department is leading the NK TCR study for patients with different types of sarcomas. And the other potential advantage of these NK cells, we call them off the shelf, because these cells do not have to be collected from the patients, do not have to be sent to a manufacturing facility where it can take up to 4 weeks to genetically engineer these cells before they can be infused. So these cells are sitting in the laboratory, and the process can take literally 3 days before these cells are ready to be infused to our patients. And the toxicity is much lower. So the first study from our group was published in New England Journal of Medicine in 2020. These are NK cells targeting the same that CAR T cells have done, CD19, and 36 patients were treated, about 50% response rate. But the interesting thing was that there was no cytokine release syndrome or neurotoxicity that was seen by CAR T cells. So that's a promising thing, but still these are earlier stages, and there are questions whether NK cells are going to be as effective as therapeutic modality as T lymphocytes. Since then, an update was published in Nature Medicine with a longer follow-up and a few more patients, more or less confirming the results that we reported earlier. So there are a number of strategies that have been tested on how to improve the efficiency and efficacy of these T cells, and at many different levels. Select patients that are more likely to benefit from this treatment, do some treatment before the cellular therapy to make it amenable to CAR T lymphocytes, and then how to make the manufacturing faster and perhaps more cost effective. As you will see that this is a very expensive treatment, and also in terms of designing these CAR T cells, how genetic engineering can be even more sophisticated to have better CAR T cells being produced. So this is the balance sheet for CAR T cells. So far, we can say that there are unprecedented response rates. I showed you some of the myeloma response rate, 95 to 98% response rates in a population where drug approval used to be obtained with 20 to 30% response rates. So this has set the bar really high. It is curative so far in at least one condition, B-cell lymphoma. And in many other B-cell malignancies, B-cell lymphoid malignancies, it has shown durable responses. But then there are a lot of drawbacks to this also. It is effective only in a subset of blood cancers, not all blood cancers. It has limited activity in solid tumors so far. Cost is exorbitant. Even in the US, only a few centers can afford to administer this. It costs about $500,000 for a dose, and it does not include all the treatment that goes before and after, including management of toxicities. The manufacturing can take several weeks. It has a lot of unique short-term toxicities that I alluded to, cytokine release syndrome and this neurotoxicity called ICANS. It may be associated with some long-term toxicities. The follow-up is short, but low blood counts, low immunoglobulin levels, because we are targeting the B cells. So patients require IV immunoglobulin replacement, otherwise they get infections. And because it is targeting those cells that are part of our immune system, infection remains a problem. And then we are also seeing nothing comes without some unintended consequences. We are genetically engineering these cells so we can disrupt some genes that may lead to cancer. So we are seeing some second or secondary malignancies appearing early after the treatment with CAR T cells, and it's not the malignancy that was treated. So someone treated with B-cell lymphoma has developed T-cell lymphoma or has developed myelodysplasia. So these are some of the other things that still need to be addressed. So I was thinking that if we talk about cellular therapy in Pakistan, what are some of the important points? First of all, it's always good to have access to whatever modern treatment because it may be useful for some patients. But keep in mind that it works only in a small subset of hematologic malignancies. There was an analysis that was done by a group of epidemiologists, and there are about 3 to 4% of patients, even in blood cancer arena, who would potentially benefit from these CAR T cells. These treatments are expensive, toxic, and require specialized centers and expertise for safe administration. It is also demanding for patients who need caregivers, housing, ICU care, and proper toxicity management. And again, I gave you some very impressive data, but there are also subtle messaging when you read these papers, when you read the advertising that goes on the side, that although the data are compelling, but pharmaceutical messaging introduces an element of hype and urgency that everyone needs it and it needs to be given now. And that is not the case. So if I have to give my conclusion, I would say that stay informed of development, try to obtain that in appropriate patient, but don't try to immediately change your practices based on early results. Use them for appropriate patients. And what you're doing for like 96% of your patients or 97% of your patients is use your best practices that you currently have available, and you will continue to offer the same service that you have done for all these years. So I think that concludes my talk. I read this little couplet when I was a medical student. It was actually on my biochemistry textbook. Birj Narayan Chakbas is a very well-known poet, and this goes, Zindagi kya hai anasir mein zahur-e tartib, maut kya hai unhi ajza ka pareshan hona. And if I have to translate into English, and it's my translation, that what is life with just the orderly arrangement of elements, and what is death? It's just the unraveling of those elements. So thank you very much for your attention, and I'll be happy to answer any questions.
So traditionally, we don't ask any questions, but I think if we got one or two burning questions, we can just deal with them. So any questions, please?
Thank you very much. Very enlightening talk. I am Muhammad. I'm working in the fundamental sciences research, working on stem cells, etc. One of the limitations in establishing CAR-T therapy, especially in other areas, is the patent with the CAR-T therapy, and that limits the use of this technology by other research centers. My question is it the same with the T receptor engineered natural killer cells? And is there some kind of, because I know some people who are trying to work on CAR-T therapy here, just on the earlier stages. Is there a way that this can be promoted? So it's very expensive, but also because it's a lot because of the cost associated with the production, that cost can be reduced here.
Absolutely. So even in the United States, so this cost is because what I gave you the cost like $500,000. So these are pharmaceutically produced CAR T cells. So they are marketed by the companies that have developed it. They are the ones who manufacture it and market it and supply it to the patients. But there are academic centers, just like we do bone marrow transplant. We collect these cells and we infuse them ourselves. So if we have our own scientists working at an academic institutions with the right equipment, they can do these scientific procedures as long as there are obviously appropriate regulatory bodies and checks and balances for a fraction of this cost. And this is where of course, this was a more general overview, but in those future developments, that's what many of these places are doing. How can we make this engineering faster, use third-party cells or off-the-shelf cells, use them at an academic institution. In fact, there's the company Miltenyi. There are academic centers that have contracted with Miltenyi and develop these cells in their own facilities and infuse them to the patients. So if this takes hold, it would make this product much cheaper and more accessible to a lot of people. And there is certainly the highest number of CAR T cells trials or patients being treated are in China. They are at the forefront of this technology. The Silta cell that I showed was first developed by a Chinese biotech firm, Legend Biotech, and it's a better CAR T than the one that was produced in the US. And they are the ones who have numerous trials. So once their products come out, other than when they try to market them in the US, they will be much cheaper. But then, yes, these are the things that can be developed right here if you have the right equipment and people who, of course, have the resources to allocate to this type of research.
Thank you,
Yeah,
thank you,
thank you
Professor
very
Kazelbash. I think we are short of time, so we'll move on to our next talk from Professor. Professor Nick Maynard from Oxford. He'll be talking and sharing his experience about Gaza with us. So, Professor Nick Maynard, please.
As I said in my earlier talk, it's a huge pleasure to be invited to this conference and to visit Pakistan for the first time. And thank you for asking me to talk about Gaza. I was asked late last night, but I've always got a few talks prepared on Gaza. It's a place that's very dear to my heart, and it gives me great pleasure to share my experiences. This photo here won first prize in the World Press Photography competition earlier this year, and it shows a lady holding her dead niece in Gaza City. And this picture won second prize in the World Press Photography competition. This is someone walking through the ruins of Khan Yunis, which is a town that Mike and I have visited on many occasions and know very well. I'm going to tell you a little bit about what Gaza is like normally and what it's like since October the 7th. But I'll start by letting you look at the CNN quote of the day for March the 22nd, 2024. I was in the States at that time. I'd been asked to go out to visit the United Nations and the Biden administration to share my experiences of what I'd seen in Gaza. And I was there with two American doctors I'd been out there with since October the 7th. And it was based on a trip I'd taken out there over Christmas and New Year, working in Al-Aqsa Hospital. And one of the doctors I was with was Thea Ahmed, who's an emergency physician from Chicago. And we both did a lot of media interviews at the time. And he was asked by the CNN reporter, what was it like in Gaza? And he said, it was apocalyptic, it was horrific, it was miserable. And I'm very sad to say it's still like that in Gaza, with no obvious end to the atrocities there. Gaza, I'm going to talk about normal Gaza. Now, Gaza's not normal by any normal standards, any standards of the rest of the world, but it's what people in Gaza have been used to for many years, and certainly what I have seen over the years. And we call it normal Gaza because that's what it is. It's a very small country. It's 25 miles long. There was a Gaza marathon quite a few years ago, but it's got a population of well over 2 million. It's the most densely populated country in the world. High unemployment, high poverty, and a median age of 17 years, which means that half the population, over the half the population, are children, which perhaps tells you why so many children have been killed out there. High poverty rate, and it's been occupied by Israel since 1967, and it's been blockaded since 2008, and it's been variously described as a large prison or concentration camp. Now, my talk is about what I've witnessed, what I've seen, and it's a humanitarian talk. It's not a political talk, but it is important to dispel some of the narratives you hear in the press. This didn't start on October the 7th. There's a long history of conflict there, with multiple atrocities being inflicted upon the Palestinian population. And I've been going there since 2010, and I've never been there. I have never been there without witnessing with my own eyes significant aerial bombardments on the Gazan population. And I'd like to just show you a picture of a great friend of mine, probably my closest friend in Gaza, Dr. Hamis Alessi, who's the most inspirational doctor and the most inspirational medical educator I have ever come across. And this is a picture from 2010 when I visited Gaza for the first time, and he took me to this hospital here, the Al-Wafa Medical Hospital. It's a rehabilitation hospital that he had set up. He was a rehabilitation doctor as well as a teacher. And this looked after patients with head injuries or spinal cord injuries, the majority of which, but not exclusively, were from war injuries. It was bombed in the Operation Protective Edge in 2014, which at that time was the conflict or the assault with the most fatalities of just over 2,000, which of course has been dwarfed in the last year. And this hospital was bombed in 2014. And when I went back there, about 2 months later, I visited the hospital site with Hamis there, and he is there standing where his office had been. And this is one of many hospitals that has been destroyed over the last 20 years in Gaza. And on the picture is Hamis, taken just in July of this year. I speak to him regularly. I haven't seen him for over a year now. And this was taken him. He stayed in Gaza City. By his own admission, he was overweight. He's lost 20 kilograms in weight. He's with his son at 5 in the morning searching for food. And at that time, they were living on animal feed and sometimes only bird seed. So there are many challenges to healthcare in normal Gaza. And it's important to realize and to understand that in the WHO definition of health for a country, core to that definition is the existence of provision of human security. And of course, that's been lacking in Gaza and to a lesser extent the West Bank for many years now. There are both social and medical determinants of poor health in Palestine. The borders are closed. The economy is exclusively under Israeli control and often disabled. There's extreme poverty and unemployment. Remember, I'm talking about pre-October the 7th, what many people call normal Gaza. Constant food and water insecurity, poor sanitation, inability to travel. 99% of the population have never left Gaza and not able to leave Gaza. And continuing energy and fuel insecurity with power cuts to the extent there's often only electricity for 2 or 3 hours a day. There are many medical challenges as well. A chronic shortage of drugs, medicines and disposables, malnutrition, I'll come on to that later because that's got much worse since October the 7th, inadequate capacity both in terms of staff and infrastructure, outdated medical equipment, refusal of patients to go out of Gaza for treatment, and even if they are allowed to go out, and as I said there, in 2022, 33% of patients were refused leave to go out there. And even if they were allowed out, nearly 2/3 of them were not allowed companions to go out. So that means children going to the West Bank, going to Al-Maqasad Hospital in Jerusalem for treatment for their cancer were going alone without their parents. And obviously a lack of specialists. There's also challenges to medical education. Mike and I have been there regularly. I've been taking a team of doctors out there from Oxford for many years, and there are many challenges to medical education in Gaza. It's often hard to get to clinical environments when there's been an aerial bombardment the night before. Limited teaching hospital facilities, although I should add that's improved hugely in the last decade, and much better senior supervision than there ever used to be. But there's always been this problem of textbook knowledge versus applied knowledge, relying heavily on textbook teaching and online teaching, but only recently has that been dynamic teaching. It's clearly hard to leave the country, although a few have managed to get out. So this is us this I think was 2019. You can see Mike there. He's actually waving to you at the moment, I think. This was a typical group that we take out. We normally take about 12 doctors out, and we spend every morning carrying out bedside teaching, at the bedside, teaching students how to take histories, how to do physical examinations. This is me teaching them the art of observation of the abdomen. And we take a mixture of surgeons, physicians, pediatricians, and obstetricians. In the afternoon, we spend each afternoon teaching on a variety of clinical case scenario stations. This is me teaching on a trauma station. Mike's at the top end there. This is one of the medical school workers being dressed up as a trauma victim, and we're teaching the skills of ATLS. This is Andrew Wilkinson, who's a neonatologist in Oxford, teaching a neonatal resuscitation station. This is me teaching on the infamous laparoscopic surgical skills competition, where the students have to move polos from one side to the other using laparoscopic instruments. Debbie Harrington is one of my obstetric colleagues who's teaching on an obstetric trauma station. This is about cord prolapse. And we have a variety of other clinical stations as well. Concurrent to that, I've been traveling out there with Medical Aid for Palestinians, which is a wonderful UK charity, to teach and carry out major cancer surgery, mainly stomach. And I've resisted so far esophageal surgery because they're not able to do that, but really helping them set up their oncology cancer surgical services, and also complex advanced laparoscopic surgery. We've helped them set up multidisciplinary team meetings. We'd actually had our first upper GI cancer online MDT set up for October the 14th last year. And of course, that was cancelled, and we had a trip set up on October the 21st to operate on the patients we had identified for that MDT. They'd built a standalone cancer hospital, which is an enormous development in Gaza. They'd at long last embrace the concept of subspecialization and central, or beginning to embrace the concept of subspecialization and centralization. So this was normal Gaza. This was me operating out there in May of last year at Shifa and European Gaza hospitals, carrying out gastric cancer surgery. I'm there with Sarah Al-Saka, who's a great friend to the Oxford group. She was the first female ever to qualify as a surgeon in Gaza. And that's me wondering why I'm there at the time. What have I taken on? Because, of course, you get delivered these patients. This was a morbidly obese patient needing a total gastrectomy. They wanted me to show them how to do a radical D2 gastrectomy. But, of course, there's no retraction systems there at all. So it was a very challenging thing to do. And I think I'm probably thinking, what have I got myself into? So that was normal Gaza. It's a beautiful country, a beautiful coastline, wonderful people there. And everyone who goes there loves the place and wants to go back. But as I've said, it has huge challenges. And then, of course, the appalling events of October the 7th occurred. And since then, the normal Gaza we know so well has changed probably irretrievably. So I'm not going to talk about lots of figures. I'm going to talk about people I've treated and people who have impacted me. But I'm going to give you some figures. This was downloaded from the United Nations website from just 3 days ago. So far, the reported casualties are 42,718 from trauma. We know that's a gross underestimate of even trauma deaths. There are many thousands of people still buried under the rubble. More than 750 healthcare workers have been killed. And the theme of this talk is going to be the war on healthcare that Gaza has become. More than 250 healthcare workers have been abducted and tortured. 179 at the last count were still imprisoned and whereabouts unknown. Multiple hospitals have been directly targeted. There are no fully functioning hospitals in Gaza, and only 17 out of the 36 are partially functional. But partially functioning means barely able to deal with the trauma. They're not dealing with anything else. It's been estimated that well over 1 million children are in need of mental health and psychosocial support. 17,000 children are now unaccompanied and separated from their parents or orphaned. There's been 1 million acute respiratory tract infections and over 500,000 cases of acute GI infections. We've heard recently about polio there as well. So let me tell you about a few people. This is my Sarah there. This is my wife, my son, 2 sons, one of my daughter-in-law, and another Gazan great friend of ours, our adopted daughter, Inas. My Sarah was a doctor. He was a medical student that we taught in Gaza many years ago. He got a scholarship together with Inas. They got Chevening scholarships to come and do masters in England and managed to get out. They're one of the very, very few who could get out. And he went back to Gaza to work for Médecins du Monde in 2023. And he was killed on November the 8th. This is him in our house eating at our table. He became a great family friend of ours. He was killed on November the 8th. He'd gone out. His brothers, his sisters and his parents were left in the house. He'd just got married. His wife had popped out. And an Israeli jet given to them by the United States of America bombed their house. And his parents and his sisters were killed immediately. And my Sarah were killed. All 5 of them were killed immediately. The brothers got back and spent the next 48 hours trying to find their family buried under the rubble. 2 days later, after 48 hours of searching, another American supplied Israeli jet bombed them and killed them. So his wife, whose family had already been killed the week before, was left alone. That is Khaled, who is a local Gazan who works for medical aid for Palestinians, who I've known for many years. They've looked after us when we go to Gaza. And he was Maisara's best friend in Gaza. And he told me about a conversation he had with Maisara the week before Maisara was killed. And Maisara had said to him, I expect to die. And this is something I've heard from many people in Gaza. They all expect to be killed. They expect to die, and they're not frightened of dying. Maisara said, I'm not frightened of dying. What I'm frightened about is being bombed and being left buried under the rubble and being denied a proper funeral. So a year later, he is still buried under the rubble and he's still been denied a proper funeral. Inas was a close friend of Maisara, and Mike and I met her quite a few years ago on one of the earlier teaching trips. She got a scholarship to come out. She's never been back to Gaza. She's never been back to see her family. I see her family every time I go to Gaza. I take them presents from her. I bring them back. When she got engaged to another Gazan man, her father asked me to give her away. So this is me giving her away at the wedding. She had her first baby last year. My wife looked after her at that time. And this is what it means to those of us who've been to Gaza. We've made very, very strong personal contacts there. Children. So there have been more children killed in the last year in Gaza than all the other conflicts in the world over the last 5 years. There's an acronym that those of us who've been in Gaza since October the 7th are familiar with, WCNSF, Wounded Child, No Surviving Family. We used to have to give that to children on many occasions when they were brought in to the hospital. This graph was produced last November, and at that point there were 136 children being killed every single day in Gaza. The average has come down to just under about 60 children per day. Just think about that figure, 60 children killed on average per day in Gaza for the last year. The other war we're very familiar with at the moment is Ukraine. The number for Ukraine is 0.7. The number for Syria, 3. Iraq, 0.6. Gaza, 60 children per day. I spent my time operating there. I'm a very subspecialized upper GI cancer surgeon. I'm not used to major trauma like this. So I learned a lot from the local surgeons there, and they likewise learned a lot from us for some of the more complex injuries. But I spent my whole time for 2 weeks with a great friend of mine, Khaled Dawas, who's a surgeon at UCLH Hospital in London. We spent a whole time operating on major thoracic and abdominal trauma, dealing with horrendous shrapnel injuries. And this was a typical scene from the operating theatre. This is what every operating theatre looked like after our cases. These patients came in extremis. This is someone we just operated on. You can see here a bit of shrapnel that we'd taken out of this patient's abdomen that had gone through the chest wall, lung, diaphragm, liver, duodenum, and colon, and had caused an untold amount of damage. And this was a typical scene day and night in the operating theatres. This is a typical scene in the emergency room at Al-Aqsa Hospital where we worked. Al-Aqsa Hospital is a small hospital, 150 beds. All the time we were there, it had 850 patients or roundabout, 20,000 people living in the hospital and the immediate surrounds, because all their relatives go there. Many displaced refugees from the north of Gaza come down there. So it was crowding like I've never seen before. And this, again, was a typical day. We'd go down and help in the ER between operations, and we'd see appalling carnage like this. Triage, we're all familiar with triage. Triage collapses completely when you have large volumes of traumas coming in like this. It was impossible to prioritize patients. And it was well known that those that had relatives who shouted the most were the ones that got treated first. It's a fact of life. It sounds awful, but it was a lottery as to who was to get treated. And I'm going to tell you about an example of that. This was a typical afternoon in Al-Aqsa Hospital. You can see me there treating a child. So I'd gone down between cases, and I want to tell you about Ala and Aya, brother and sister, who were admitted to the ER there. I came down between cases. It was chaos. There'd been a large bombing of Nusrat camp, which is a refugee camp near the hospital, and dozens upon dozens of people came in, some of them dead, but many seriously injured. And I walked into this chaos, and the first thing I saw was this little boy lying on the floor of the ER waiting area by himself. I subsequently found out his parents had been killed by the bomb, but no one had seen him. No one had triaged him. He'd just been dumped there. And the first thing I saw was a big hole in the side of his chest. And you could see his lung, you could see his lung collapse, you could see the air being sucked into his chest, and he had a hole in his head as well from shrapnel, but he was alive. We bundled him up and took him into the resuscitation room, which is this room here. You got used to treating people on the floor there because there were no trolleys. There was only one trolley in the resuscitation room. That child had been lying on the trolley there. You can see the big bandage around his head. He had sustained a fatal brain injury, but he hadn't died. He was dying, but he hadn't died. There was nowhere for him to go other than lie on the floor of the resuscitation room while he slowly died. We're there treating this 6-year-old boy. We're putting a chest drain in and resuscitating him. There is Aya, who is Allah's 8-year-old sister. She didn't have fatal injuries. She had a badly fractured leg, which was displaced. And that leg, of course, needed to be straightened immediately because she had no pulses in her feet. Now, this was a day in Al-Aqsa Hospital where we had no pain relief at all. We'd run out of all painkillers. So none of these children could be treated with pain relief. This girl had to have her leg straightened by the orthopedic surgeon, and without any analgesia at all. And I can still hear her screams as that was done. 3 hours later, I had to go back and operate then on one of these patients. But 3 hours later, another 8-year-old girl came in, and my friend Debbie Harrington had to treat her. She had burns that were so severe that there was no chance of her surviving. She wouldn't have survived in Oxford, in Lahore, in New York, certainly not in Gaza. She was going to die beyond any doubt. The burns were so bad on her face that you could see her facial bones through the burnt flesh. But again, we had no pain relief to give her. We knew she was going to die. She took hours to die, but she died in agony, in public, on the floor of the ER. Now, there are many Allahs, there are many Ayahs. These are examples every single day that we witnessed, and doctors continue to witness there. So the healthcare system has been completely disabled over there. There's been no electricity since October the 7th. Many of the hospitals continually run out of fuel so that you cannot run ventilators, so you have patients dying on ventilators. You will have heard about some of the babies in incubators who died because there was no fuel to keep them going. In Nasser Hospital, 6 babies were discovered 3 or 4 weeks later after the Israeli military had taken over the hospital, and they were discovered rotting, literally decomposing, because they'd been in incubators which had no electricity. Often no drugs, often no lights in the theatres. Colleagues of mine had to operate using mobile phone lights, no blood products. We often ran out of surgical gloves. So you had to wash gloves in between operations. For the whole of my second trip out there, for 2 weeks, we had no surgical drapes at all. We had to make up our own drapes. Triages collapsed, as I've talked about. Now, Shifa Hospital, you'll remember this hospital. It's an iconic hospital. It's older than the State of Israel. 1947 it opened. It's a wonderful hospital. I've spent many weeks there over the past. It's a major trauma center for Gaza, the biggest hospital in Gaza. And this is what it looked like just a few months ago. It's been completely destroyed. Now, they are rebuilding with what, I don't know, but they're now functioning again on one level. They're doing some emergency treatment and some very basic operating. But again, this hasn't just been bombed. The Israeli military have been in there. They've dismantled the whole infrastructure of this hospital, as they have done with other hospitals. They've destroyed the scanners. They've been into the laboratories and destroyed the laboratories. They've destroyed all the oxygen supplies. And when they left eventually, and I've heard this again from friends of mine who've stayed in Gaza City, who still go to Shifa Hospital, the bodies of 300 Palestinian civilians were found, and they all were handcuffed with hands behind their back, dead. This is a young plastic surgeon I didn't know well, but I met him when I was there in May of last year. He was one of the ones who was found dead. He had a bullet, again by my colleagues, he had a bullet wound in his head and his hands were handcuffed behind his back. His mother was a physician in the same hospital, and she was beside him, likewise killed through a bullet and handcuffed. This is a young boy called Ziki, who we got to know well. He was a 10-year-old boy, we think. He didn't know his age. His whole family had been killed in the first week of the atrocities. He was living in the grounds of Al-Aqsa Hospital with no family at all, one of many orphans there. And he used to work with the doctors and the nurses. He worked with the paramedics. He'd sometimes go out with the paramedics to retrieve bodies. And this is the morgue, the makeshift morgue. That the actual morgue was full up of dead bodies. This is another room. He used to take the bodies to the morgue. Imagine what the future holds for that boy. And of course, they are now discovering many, many unmarked mass graves in Gaza to deal with all these people who've been killed. Again, I'm only talking about what I have witnessed. There's a lot of misinformation out there, but these are two people I met when I was out there, and I took audio testimonies from these individuals to be used, and they are being used. This is Haitam, who's a young doctor who was there. He didn't want his face shown. And this is Sari, who's a young operating theatre nurse with whom I worked for the last 2 weeks. Both of them had been abducted by the Israeli military. Haitam from Nasser Hospital in Khan Yunis. He'd been abducted and was incarcerated for 62 days. Sari from the Indonesian hospital, which has been attacked again recently, you may have heard about in the last few. He was abducted in January, I think it was, and incarcerated for 53 days. They were both released eventually, and they both told very similar stories. And this has been, again, repeated from other witnesses, how they were handcuffed, how they were blindfolded. They were not allowed to lie down for the 60 days they were there. They were on their knees or sitting. They were beaten daily, sometimes up to 12 hours a day. They had dogs set on them regularly and attacked by the dogs, and many people died under these experiences. And indeed, the Euromed Human Rights Monitor has interviewed over 100 Palestinian detainees who all give very similar stories. And there are probably thousands of Palestinian civilians who've been detained arbitrarily, disappeared, tortured, and many of them have been killed. The process of deconfliction is there to protect humanitarian and aid workers out there so that you can go about treating people imagining you are safe from the military action going on there. Now, that has failed completely in Gaza. You may remember the Grand Central Kitchen convoy, which was bombed, and several Gazan healthcare workers and foreign aid workers were killed by this. This is a picture of the intensive care unit of Al-Aqsa Hospital, and that was taken on January the 5th of this year when I was operating in the operating theatre on a young lady who had major thoracic and abdominal trauma. And when you're there for the whole of that time, you're hearing bombs going off the whole time. All night long, the place is being bombed. You can't sleep properly because the house is shaking. So when you're working in theatres, you're hearing bombs going off the whole time. You don't get used to it, but you sort of carry on. So there were bombs going off all the time I was operating that day, and I came out to find there was more chaos than normal. And this was a big hole in the wall of the intensive care unit, and that was as a result of a direct missile attack from the Israeli military on the hospital. While there were quite a few foreign doctors and local doctors working, we had to evacuate straight away. And this was the house we stayed in. This was a week after we left. We stayed in this house for the first trip, and the second trip we lived in the hospital. This was bombed by an Israeli jet a week after we left. There was another team of UK doctors in there who were asleep at 6 o'clock in the morning together with some local Gazan healthcare workers. And this missed the main part of the house by 5 meters. No one was killed. They all got shrapnel damage. But again, direct targeting of a facility housing healthcare workers. And when the Israeli government were challenged about this by David Cameron, our then foreign secretary, they said, oh, well, we're very sorry, it was collateral damage. We were aiming for the house next door. Well, this house was chosen because it was 200 meters away from the nearest building. And this was in Al-Mawasi, which you may be familiar with the Israelis continually call the safe area. Well, it's not safe. So I'm going to finish up by talking a bit about malnutrition. This was the main narrative from my last trip out there, and I was last there in May of this year, when the IPC had already designated northern Gaza as a famine area and the rest of Gaza as in danger of imminent famine. And it's been estimated that over 96% of women and children under 2 are malnourished, and 50,000 children or more require treatment for malnutrition. Of course, this is the basis upon which South Africa has put to the International Court of Justice the accusation of genocide, that starvation is being used as a method of war. So we know about the effects of malnutrition. You get this vicious cycle of immunosuppression, poor tissue healing, infectious complications, increased metabolic demand, completely unable to give nutritional support because we had no nutritional support to give them. So this vicious cycle. So we had multiple wound breakdowns, leaks, and we defunctioned whenever we could, but you can't do that with duodenal injuries and proximal jejunal injuries. Multiple awful intracutaneous fistulae, the like of which I've never seen before, and of course no nutritional support. So let me tell you about 2 young ladies I treated. Tala, 16-year-old girl, I haven't got any photos of her, and Lama, 18-year-old girl. This is Lama here. Both malnourished. You can see she's very edematous here. Both of them previously fit and healthy, both of them profoundly malnourished because they'd come from the northern part of Gaza. They both came in with shrapnel injuries to their abdomen. Serious injuries, intestinal injuries, but injuries that we would have expected them to have survived if they had been otherwise fit and healthy. This is Lama's abdomen. She leaked from everything. She had a duodenal injury. She had multiple bowel injuries. We obviously defunctioned as much as we could, but she had the most terrible intracutaneous fistulae. We had no nutritional support to give her, and she died under our care. Likewise, Tala, similar injuries. They both died within about 9 days of each other, entirely preventable deaths. This is the sort of patients, this is someone who had been treated in a field hospital. The abdominal wall had fallen to pieces. They had, this was a hole in the side of the abdomen through which you could see the liver. That's where the shrapnel had gone in, and nothing was healing. Again, he was alive when we left, but I don't know whether he survived. This was another one who actually managed to be medically evacuated to Egypt for treatment. He again had multiple fistulae that we managed to keep him going, but he was medevac eventually. And of course, we formed multiple stomas, and of course, there were never enough stoma bags. These patients were discharged back to their camps without proper stoma bags, without wound management resources. And you can imagine how appalling it was for them to manage themselves like that. So we talked earlier that the official figure is 48,000 deaths. This was the paper produced by the London School of Hygiene and Tropical Medicine back in February, which estimated that there were going to be over 85,000 excess deaths and possibly as many as 200,000. And you may be familiar with the Lancet publication from July, which estimates there are already 186,000 people dying of either trauma or excess deaths. And of course, the amount of deaths of people dying from communicable and non-communicable diseases will be enormous, particularly from malnutrition. But there's no cancer being treated, not being diagnosed, let alone treated. They can't dialyze all the patients in renal failure. They've got 6 dialysis machines functioning in Gaza when I was last there. People having myocardial infarctions, having strokes, aren't being treated. So I'm going to finish up. There is no doubt in my mind, there is incontrovertible evidence that I've seen with my own eyes of healthcare facilities being directly targeted, healthcare workers being killed, abducted and tortured, and the healthcare system has been deliberately destroyed, dismantled to make the place uninhabitable. And I think we all fear that the amount of excess deaths will far exceed the number already reported. What can you do? Everyone can do something. I've just saw this is a wonderful photograph taken just the other day in Karachi, a massive march in support of Gaza. This was taken the other day of 60, I think, medical students arriving in Pakistan for their medical education. Wonderful. It's a damn sight more than our country is doing. So well done. This is very, very important. We can all talk about it. We can all educate and make everyone aware of what's going on. March, protest, boycott. We should all be doing that. Donate, of course, volunteer to help, and help with the medical students. And I think whether we're individuals, whether we're society, whether we're governments, whether we're academic institutions or medical institutions, we will all be defined by how we react to what's been going on in Gaza in the last year. These are two charities I would like you to take note of. Medical Aid for Palestinians is the charity that takes me out to Gaza. There's a QR code if you're interested. They're wonderful. And this is a charity, a smaller charity, that I am chairman of the board of trustees of. And we raise a lot of money. About 98% of what we raise is for Palestine to support medical education and medical teams out there. Thank you for giving me the opportunity to share all this. And I'm happy to take any questions if there's time.
Thank you. That was incredibly moving. I'm not sure if anyone has anything to say. I certainly can't imagine what to say, really, other than to say that while we hang our heads in shame that we haven't done anything personally, but to thank you and Mr. Silva and all your colleagues in Oxford and elsewhere who have helped these poor, unfortunate people. I think Dr. Kizilbash would like to say something. And obviously anyone else who wants to say something, please do.
Sure. Thank you very much. First, for your service, and second, for increasing the awareness. Just one question. So, of course, you showed us the charities and various ways, but you have talked to people in the media also, especially in your own country or where I live in the United States. And of course, we all know the limitations there. What do you think one can do to increase the awareness with the constant assault that, it's in response to what was unleashed on October 7th? How can you basically take this conversation a step further? And with people who are totally resistant to it, did not start on October 7th.
So it's a very good question. It's a very difficult one to answer. I think a lot of people are doing a huge amount, and seeing those mass marches in Karachi. I've been on marches in London when there's been 500,000 people walking through London. It's quite remarkable to witness. So I think that is very powerful. And even though I think Gaza has been failed by Western governments, I don't know what your government's done, but our governments have done nothing. Your government in the US, our government in the UK, I think they've been at best quiet, at worst complicit in this genocide, to be honest. But I think actually the tide is slowly turning. I think there's been such a mass uprising of revulsion from people on the ground about what's happening that politicians are being forced to listen. I don't think we're seeing any real changes yet, but I think they are paying attention to it. So my answer to your question is, there's a very limited amount that individuals can do because the power lies within our politicians and they're ignoring it. There's a lot of politicians in the UK who I've met up with who are incredibly sympathetic and are doing what they can. And in the US, I've met people in the Biden administration out there, and I was very impressed by the passion amongst some of the lower tier, but clearly that's not. So I think we just carry on doing, as I've said in that slide, talking about it and making people aware and marching and protesting.
Looks like no one else has any questions. So thank you again, Nick Maynard, for that fantastic talk. It was very, very illuminating. And again, thank you all, you and your colleagues, for your service.
Thank you very much for listening.
So thanks a lot for the participation. That will conclude our plenary session. Thank you.
See
So
you.
remember to come tomorrow. We've got essentially the memorial final session tomorrow, late afternoon, where 6 studies, selected studies, will be competing for the medal. Thank you.
But the rest of the day starts at 9 o'clock sharp. So we'll see you then. Thank you.
Yes, of course.